Good evening, everyone. Thank you for joining us for today's Emerging Strategies to Eliminate Cervical Cancer Burden in Florida. It's a webinar organized by the Florida Society of Clinical Oncology in partnership with FLASCO's Diamond Elite partner, SeaGen. FLASCO is a member-supported state society that focuses on supporting and representing the oncology workforce of Florida. Together, FLASCO is the voice of oncology in Florida. Many of the individuals presenting and participating in this webinar are members of FLASCO, and we appreciate their support. I'm Dr. Nally McKenzie. I'm a multilingual award-winning GYN oncologist at Advent Health Cancer Institute, and I currently serve as the director of GYN Oncology Fellowship. I hold several positions, including global health equity, lifestyle medicine, oncology, and I frequently volunteer throughout ASCO, IGCS, and SGO through numerous platforms. My passion is global health equity, cancer survivor, and lifestyle medicine and oncology. Before we begin the presentations, we'd like to thank SeaGen for sponsoring this webinar and making it possible for us to share this important information. I'd also like to let everyone know that this webinar is being recorded so that those who are unable to attend can view it at a later time. Please note that your lines will be muted for the duration of the webinar. Toward the end of the meeting, we will host a Q&A, and we encourage you to submit questions or comments via the Q&A chat feature at the bottom of your screen. We will discuss as many questions as time permits. It is my sincere honor at this time to introduce the remainder of the panelists for this evening's educational program. I will briefly introduce them, but please read their impressive bios in the meeting material that was emailed to you earlier. Now I'd like to introduce the other three panelists, which include Dr. Teresa Kuhn, who is a GYN Oncology Fellow at Advent Health Cancer Institute. She has a long-standing interest in cervical cancer treatment and prevention since entering her OBGYN residency at Rutgers, New Jersey Medical School. She has completed 3 additional fellowships in surgical ICU at the University of Connecticut, advanced pelvic surgery at Emory, as well as lower anogenital screening and treatment fellowship. Dr. Marilyn Wan is professor of obstetrics and gynecology and reproductive sciences in the Division of GYN Oncology at the University of Miami Miller School of Medicine and the Sylvester Comprehensive Cancer Center. She serves as the director of translational GYN oncology research and co-leads the GYN cancer site disease group at the Cancer Center. Hae-Suk Chun is a GYN oncologist in the gynecologic program at Moffitt Cancer Center. Dr. Chun completed her residency training at the OBGYN program at Baylor College of Medicine in Houston, Texas, and her fellowship at Moffitt. Dr. Chun continues to pursue her research interests, which include outcomes in gynecologic malignancies and personalized treatment options for patients with gynecologic malignancies. Dr. Chun is a clinical trials medical director in the Department of Gynecologic Oncology at Moffitt Cancer Center and oversees clinical trials in the GYN department. Thank you, speakers, for offering your time and knowledge with us here today. What I would like to do at this time is go on and share with you my presentation slides as your speaker today. So today, my speakers will speak on different topics, including disparities in cancer care, screening, as well as treatment strategies. And I'd like to give you a brief overview of the HPV virus, which is linked to cervical cancer. The alpha-9 species concentrate most of the known carcinogenic types, which include 16, 31, 35, 33, 52, 58, and 67, with an evolutionary tree based on papillomaviruses, which align with their E1, E2, L1, and L2 encoding regions. The site of infection is the peribasal cells, which are undifferentiated stem cells of the epidermis in the transformation zone of the cervix, and which is most accessible during puberty, pregnancy, and during oral contraceptive use and or toxic substances placed within the vaginal canal. HPV infection and replication occurs first through the access of these parabasal cells through microabrasions, whether they are mechanical or chemical. Low-grade SIL supports productive viral replication and subsequently progresses to invasion of the cancer via the integration of the HPV genome into the host. There are several known cofactors that have been documented through epidemiologic studies, which include oral contraceptive use, hormonal influences, parity, other sexually transmitted infections, smoking, nutrition, certain polymorphisms in the HLA genes, and specific genotypes, as well as other molecular variants. There is a clear delineation from integration of the genome into the host and then subsequent expressions of oncoproteins, including E6, E7, and downregulation of E2. There's also a direct progression that can be seen histologically with a very well-defined nomenclature. Dr. Kuhn will go over the screening guidelines, which may differ by age group. And there are clear strategies for screening as well as evaluating patients who have on Pap smears low-grade SIL or high-grade SIL. And we know that the likelihood of regression, persistence, or progression of disease is linked to the degree of dysplasia. Management of high-grade SIL is more aggressive than low-grade SIL and can involve numerous strategies. And recently there were guidelines that changed that discusses the management of CIN 2 to 3, and this sometimes can differ by age group. Dr. Marilyn Wong will go into detail discussing the disparities that exist within cervical cancer, screening, treatment, etc. But know that there are numerous measures that all are linked to disparities in cervical cancer, whether it speaks to incidence, prevalence, mortality, screening rates, and stage of diagnosis. We are particularly concerned with the fact that of these cancers, that affect women, cervical cancer tends to predominate in the early age groups and reproductive ages. And US statistics shows us that local, distant, all stages, we continue to see racial disparities. Florida is among the top 10 for incident cervical cancer based on a 2020 report. And this may be due to unequal uptake in HPV vaccines, and definitely there are differences in initiatives to improve health by state or territory. The CDC has identified through geomapping certain areas in the country that are more vulnerable, either because of lack of transportation infrastructure, education, information deficits, cultural factors, and language barriers. And if you look at the heat map of Florida, you will definitely see some regions that are considered to be highly vulnerable. The risk of cervical cancer is strongly related to these vulnerabilities, including the working poor, the underserved, and the underinsured. And there are potentially multiple strategies that could help here. Vaccination rates can differ by age and recommendations, and Dr. Kuhn will go into depth here as well. And I'd like to think about future directions and opportunities, and we can maybe further discuss that later, including self-collection, cervical swabs, geospatial mapping of high-risk group, and government funding for HPV vaccination like they exist in other states. Here's an example of a self-swab that patients could easily use, and maybe that's the future. Maybe the future is HPV testing and then subsequent cytology based on these self-home tests. Something to consider, food for thought. And I will now pass on to Dr. Kuhn to discuss her presentation. Thank you so much.
Good evening, and thank you for inviting me to speak on this important topic. As Dr. McKenzie mentioned, I'll be speaking on cervical cancer screening and prevention.
Can everybody hear Dr. Kuhn? Dr. Kuhn, we can't hear you.
Can you hear me now?
Yes.
Okay. All right, sorry, let me start over. So again, thank you for having me tonight to talk on this important topic. As Dr. McKenzie mentioned, I'll be talking on cervical cancer screening and prevention. So there are currently multiple different organizations that make cervical cancer screening guidelines. Currently 3 governing bodies in our specialty: the American College of Obstetrics and Gynecology, the Society for Gynecologic Oncology, and the American Society for Colposcopy and Cervical Pathology, support the recommendations by the U.S. Preventative Services Task Force, which say that screening should start at age 21, and this should be done with cytology alone, so just with a pap smear. This can be done until age 29, and if there are abnormalities on the pap smear, then a reflex HPV should be done. And this should be done every 3 years if the pap smear is normal. The reason we do not do co-testing automatically or primary HPV testing at this young age is because the literature has shown there's a high clearance of HPV in these young women, making them susceptible to colposcopies and biopsies and procedures. By doing this HPV testing really renders more risk than benefit per what we've found in these studies. However, we've learned from the ASCCP, the new risk-based management that Dr. McKenzie was talking about, that as a woman ages, HPV, as opposed to cytology, infers a higher risk in the future of developing cervical cancer. So there's been a shift in testing for cytology, and even cytology plus HPV, to testing for just HPV to screen for cervical cancer risk. Therefore, in women 30 or older, the recommendation is now to do primary high-risk HPV testing. Some literature has shown that this testing can be considered as an alternative for average risk patients 25 to 29 as well. But for those 21 to 24, the gold standard is still to do cytology only with reflex HPV. Testing should be done with primary HPV testing every 5 years if it's normal. There are 2 high-risk HPV tests approved by the FDA currently for those 25 and older, and many institutions have them. However, if your institution doesn't have them, it's still acceptable to perform cytology every 3 years or co-testing every 5 years. All 3 screening strategies are effective, and each provides a balance of benefits and potential harms. Data from clinical trials, cohorts, modeling studies, they all show that among average risk patients from the age of 25 to 65, that primary high-risk HPV testing and co-testing detect more cases of high-grade dysplasia than cytology alone. But again, high-risk HPV-based testing is associated with an increased amount of colposcopies, biopsies, and false biopsies, so this has to be weighed. The current recommendation is to stop screening in women age 65 and older if they have appropriate and negative prior screening tests. For those who have had a total hysterectomy with the cervix removed, testing also should not be done if there was appropriate and negative screening done prior to the hysterectomy. However, for example, if the patient was having a hysterectomy for some form of dysplasia, follow-up would be warranted. And I just wanted to take this moment to talk about the ASCCP app for risk-based management. There is an app that was put out in 2019 when these new risk-based management for HPV testing came out. And you can get this on your phone, and it can help you to manage your patients if you put their previous history and PAP results in, because there are many different algorithms for when you do this screening and you get abnormal results. And now I want to talk about just some primary prevention. There have been multiple HPV vaccines. First, the bivalent vaccine came out, which covered high risk 16 and 18. And these are known to cause approximately 66% of cervical cancers and the majority of other HPV-related cancers in women and men. However, this vaccine was only approved for women. Then we came out with the quadrivalent vaccine, which was made to extend to cover high-risk strains 6 and 11, and was approved for men as well. As we've discovered more high-risk strains, a 9-valent vaccine has proven to be the most effective vaccine and covers 5 additional strains than the quadrivalent. And it has been shown to cover strains of cervical cancer that covers an additional 15%. It's said that this vaccine could potentially provide broader coverage and prevent up to 90% of cervical cancer cases worldwide. Therefore, the CDC made recommendations for the Gardasil 9-valent vaccine in 2016. It's best if patients are vaccinated prior to the initiation of sexual intercourse, which we know is how HPV is acquired. And the recommendation is to start at age 11 to 12 in boys and girls, but this can be considered, you can consider starting it as early as 9 years old. Many pediatricians' offices are making this part of their regular vaccine schedules. And it's recommended right now to vaccinate up to age 26. However, there is some emerging data that there are protective measures for those who have already initiated sexual intercourse, and even for those who have an HPV infection, as it can still be protective. Therefore, in a discussion with your patients, it can be considered for those aged 27 to 45 years of age. This slide is a little busy, this table, but I just wanted to touch base a little further on vaccinating those that are 27 to 45 years old and discuss this Future 3 study that was done. It was a phase 3 randomized placebo-controlled multinational double-blind study. They enrolled over 3,000 women. They were actually aged 24 to 45 in 7 different countries. Participants were randomized to receive 3 doses of the quadrivalent HPV vaccine versus placebo and followed up for up to 10 years. Participants who had received placebo or an incomplete regimen of the HPV vaccine were then offered the vaccination. So 2 cohorts were assessed: the early vaccination group, who received the HPV vaccine during the base study, and the catch-up vaccine group, who received the placebo during the initial base study and then offered the HPV vaccine thereafter. Again, there's a lot going on in this table, but just in summary, after the catch-up group received the vaccine, the incidence rate of HPV 6, 11, 16, and 18 related dysplasia and condyloma in the catch-up group during their long-term follow-up was similar to the rate in the early vaccine group during the base study when they had received their vaccine, as well as during their long-term follow-up. So this result shows that the HPV vaccine provided protection against HPV-related disease after the HPV vaccine was administered in the catch-up group in this older population. So adults remain susceptible to acquire new HPV vaccine-preventable infections. In this study at the baseline trial visit, the most prevalent infections contained only one HPV type, and a majority of the participants were HPV DNA negative to all 9 HPV types covered by the 9-valent vaccine, and thus would gain protection from the vaccination. Additionally, it found that the HPV vaccine prevents reinfection in women with serologically evident previous HPV infection and provides protection from subsequent disease after a surgically treated HPV disease. These results support a catch-up vaccine program of sexually active adults who haven't previously been vaccinated in their younger life. Vaccination of adults may be important in obtaining rapid reductions in the incidence of all HPV-related cancers and diseases worldwide, and is important information for you to know as you discuss vaccination with these patients in your practice that are older, and maybe one of the strategies, that Dr. McKenzie was talking about to target some of our patients who didn't get the vaccine earlier in their life. As far as dosing, the CDC recommends in those younger than 15, they receive 2 doses of the 9-valent vaccine at month 0, and then again at in 6 to 12 months from then. 3 doses is only recommended in this age group if the patient is immunocompromised. For those older than 15, 3 doses is recommended at month 0, 2, and 6. If patients have had previously received the complete bivalent or quadrivalent vaccine, it's not currently recommended to redose them with this 9-valent vaccine, as most cervical cancers are caused by 16 or 18, which all the vaccines cover. If a patient is in your office and is discussing wanting to get additional coverage with the 9-valent vaccine, there obviously should be a discussion, but studies have not shown any serious side effects in doing this, and only show potential benefit. If patients have not completed their series, it can be completed with the 9-valent vaccine. So if their first dose of the bi or quadrivalent was given before their 15th birthday, you would give them 2 doses of the 9-valent. If the bivalent or quadrivalent was given after their 15th birthday, then you would give them the 3 doses of the 9-valent. And additionally, the vaccine is not recommended during pregnancy, but I have seen it been given to women in the hospital postpartum, and there's a great opportunity to capture these patients that, you know, may not otherwise receive it, and then they can come back for their postpartum visit and receive their second vaccine. And in my previous institutions, this is the way that we were able to vaccinate people. And that's all I have on screening and prevention.
Thank you so much for sharing your insights with us, Dr. Kuhn. I'm going to remind our attendees, and I'm going to ask you to reserve your Q&As or chat box below until the end, when we are able to address all questions. I would like to kindly ask Dr. Marilyn Wong to turn on her camera at this time, take your microphone off mute, and start sharing your slides, please.
Great. Thank you, Dr. McKenzie. Can everyone see my slides?
Yes.
Great. Thank you. So I want to thank Dr. McKenzie and FLASCO, as well as SeaGen, for the opportunity to speak about a subject that's near and dear to my heart: disparities in cervical cancer, with a funnel down to Florida. So just briefly, global cervical cancer mortality rates tend to affect areas of the world with the highest disease burdens are in Southeast Asia, Latin America, and Sub-Saharan Africa, with the countries with the highest incidence largely in Africa, including Malawi, Zimbabwe, and Tanzania. The huge disparity in the incidence rates between high and low income countries are largely due to unequal access to preventative treatments and effective screening. In fact, nearly 90% of deaths from cervical cancer occur in these low and middle income countries. So looking at the US compared to worldwide, the incidence in 2022 of cervical cancer is 14,100, which is a slight increase from 2015. And this is similar to the trends worldwide, with the incidence in 2020 at approximately 600,000 compared to 569,000 back in 2018. And similarly, the mortality rate has increased slightly in 2020 with approximately 4,280 deaths, similar to that seen worldwide at 342,000. And cervical cancer is the 4th most common cancer in women worldwide and the 7th most common cancer overall. In the US, cervical cancer largely does not rank in the top 10 most common cancers or most common cause of mortality due to effective prevention and screening methods. So cervical cancer in general, as Dr. McKenzie and Dr. Kuhn have already outlined, affect women at a median age of 50 years. But approximately 50% of cases in the US are diagnosed in women under the age of 35, placing a significant burden on reproductive age women. The good news is that there are effective prevention strategies. So HPV infection is believed to account for about 95% of all cervical cancers, And there are an estimated 79 million people infected with HPV, and it affects about 85% of people during their lifetime. For most people, HPV clears on its own, but unfortunately, we still don't know who those people are that are going to be able to clear the virus and who will not be able to clear the virus. And for those people who are not able to clear the virus, it could cause certain cancers and diseases. And there's no way for us to identify patients currently. So additionally, there are an estimated 14 million new HPV infections in the US each year, and an estimated 50% of new HPV infections occur in adults over the age of 25, highlighting the importance of vaccination. So what are the missed opportunities within cervical cancer screening? So again, 95% of all cervical cancers are preventable through vaccination and screening. Unfortunately, more than 50% of all new cervical cancers occurred in women who have never been screened or have not been screened in the last 5 years. And this is from 2012. About 8 million women were not screened in the last 5 years, and 7 out of 10 women who were not screened had a regular doctor and had health insurance. And as you can see at the bottom, cervical cancer usually takes on average about 7 years to progress from normal cells to pre-cancer to cancer cells, lending itself opportunity for vaccination as well as screening. So using the National Health Interview Survey data from a study published earlier this year, this demonstrated an increase of women overdue for cervical screening that jumped from 14% in 2005 to 23% in 2019. And when the data was analyzed by race and ethnicity, Asian women were more likely to be overdue for screening in 2019 at about 31%. And not surprisingly, uninsured women were likely to be overdue for screening. And the reasons that were provided for the lack of timely cervical screening was maybe harshly be due to changes in guidelines causing confusion among providers, and reported by the patients on the right side of the screen. The most common reason was the lack of knowledge among patients. So the World Health Organization has established a global strategy for cervical cancer elimination by 2030, with 3 key pillars announced in August of 2020. And the goal is for all countries to reach and maintain an incidence rate of below 4 per 100,000 women, and each country should meet the 90-70-90 target by 2030. And this is vaccination, full vaccination of 95% of teens by the age of 15, which is a little bit more ambitious than the Healthy People goal in the United States of 2030, with the goal of getting to 80% vaccination. The screening rate of 70% screened using high performance tests at least twice in a woman's lifetime, ideally around the age of 35, and again by the age of 45. And then treatment, 90% of women with precancer treated and 90% of women with invasive cancer managed. So this data is from 2020, where the estimated US population was 329.5 million, with just over 50% women. The crude cervical cancer incidence per 100,000 in 2020 was 8.1, which is currently double the goal rate of the WHO initiative. And the age standardized death rate shown on the right was about 4 per 100,000 in 2019, which has largely remained unchanged in the past 20 years. So when we look at HPV trends in the United States, HPV vaccine, as has been mentioned, was approved by the FDA since 2006. And it provides protection against 90% of HPV strains that can lead to cervical cancer. The vaccine has been shown directly to decrease the incidence of cervical cancer in countries such as Sweden using large population databases. And as of 2020, only 58.6% of adolescents 13 to 17 had received all recommended doses of HPV vaccination in the US. So looking at the same data of teens from 2016 to 2020 on the right, side of the graph, girls were more likely to be vaccinated than boys, though the gap is closing. And in 2020, it was approximately 60% girls and 55% boys fully vaccinated. The graph on the left looks at vaccination uptake by race and ethnicity, with Asian adolescents achieving a vaccination rate of about 65%, while Native American, Alaskan, and Hispanic adolescents reached about 58%. Black adolescents 50%, and white adolescents fell just below 50% in 2019. And again, this is trends in the United States. So looking at vaccination in the US in 2017, this is just a visualization of the rates across the country. In 2017, we see the majority of the states falling well below the 52% average, and only one state above 67%, and that was Rhode Island. And while you can see on the right in 2021 for these teens, we have made significant strides in the last 4 years. No state has achieved the 90% vaccination rate set forth by the WHO, and only Rhode Island has met the 80% at 83% for healthy people 2030. Vaccine is available through the Federal Vaccines for Children program in all 50 states, Washington, D.C., and 8 U.S. territories. And as of July of 2020, there's only 5 jurisdictions, Rhode Island, Virginia, and Washington, D.C., Hawaii, and Puerto Rico, that require HPV vaccines for school attendance. So let's look at the data set for Florida. Vaccination rate in 2017 for teens was about 40.4%, but has improved to about 52% in women in 2020. And for males, it was about 50%. But we're still well off the target of 90% by 2030. So looking at 2021, you can see there's been a bit of a dip, largely due to the COVID pandemic. But Florida currently ranks 41st out of 50 states for vaccination rate. And unfortunately, we're not trending in the right direction. And when we look at vaccination by race and ethnicity in Florida, with the Black adolescents in Florida are achieving the highest vaccination rate at 63.2%. And on the right, I've depicted some graphs from the Florida Health Department website from 2020 for HPV vaccine completion for teens 13 to 17 by race and ethnicity, as well as by county, which demonstrates a wide variation of uptake. So looking at the top graph, with Black teens, the highest rate of vaccination was in Levy County at 74.2%, and all the way down to Collier County with a low of 16.5%. And then when we look at the Hispanic teens, the highest rate of vaccination was achieved in Hamilton County at 87.8%, but as low as 11.1% in Union County, both of which are in the northern Florida. And then among white teens, Okeechobee County achieved a rate of 64.9% with a low of 13.5% in Glade County. And unfortunately, there was not enough data for American Indian, Alaskan, Native, Asian, and Pacific Islander to be represented. So when we look at the cervical cancer profile in Florida, the overall incidence of cervical cancer in Florida is 9.2%. And the highest incidence of cervical cancers are here in the Florida Panhandle, where the incidence is as high as 48 per 100,000 women in Jefferson County and 36 in Gulf County, where both of these counties have HPV vaccination rates of only about 34%. And then down here in Broward and Miami County, where I'm currently located, the rate of incidence is about 9.1 in Broward County and 8.9 in Miami-Dade. So Florida demographics, Florida is the third largest state with the largest and fastest growing population over 65, which is largely not a surprise to anyone here. However, Florida did not expand Medicaid, which contributes to the lack of insurance in poor and median income households. Florida has the 4th highest population of uninsured residents of all states, with approximately 2.8 million residents going without insurance in 2019. In prior studies examining geographic disparities in the U.S., rural and suburban counties tended to have higher rates of cervical cancer, and mortality rates were substantially higher in these areas, particularly among Black women. So when we look at the geographic disparities in Florida, this is a recent study that looked at the risk ratio with 95% confidence interval for age-adjusted cervical incidence rates in Florida from 2014 to 2018. Cervical cancer incidence is about 15% higher among rural residents compared to urban residents. And the cervical cancer incidence demonstrated the largest disparity with a 52% higher risk among residents of high poverty areas compared to residents in low poverty areas. So when we look at these forest plots showing us the disparity risk ratio, again, with a 95% confidence interval, estimates for age-adjusted cancer mortality rates for the same period. Not surprising, cervical cancer mortality is 34% higher in rural areas compared to urban areas, and 64% higher in high poverty areas compared to low poverty areas. And this is statistically significant related to high poverty areas, but not to rurality. So when we look at data from the U.S. Cancer Statistics visualization tool from 2021 using data from 1999 to 2019, this was just released earlier this month. Among Black non-Hispanic women, cervical cancer is the 9th most common cancer and the 10th most common cause of cancer death. And among Asian and Pacific Islander women, the 10th most common cancer. Among white, non-Hispanic, Hispanic women, and Hispanic women, cervical cancer does not rank in the top 10 for incidence or mortality. So as we consider disparities in cervical cancer care, we need to systematically address the complex interrelated social, clinical, behavioral, cultural, environmental, genetic, and biologic factors. We must identify, quantify, and understand the causes of cancer health disparities in order to develop and implement innovative strategies to achieve cancer health equity. Some items to consider include clinician barriers, such as personal bias, limited time, patient obstacles, such as limited information, financial challenges, distrust, and language, clinical trial hurdles, such as multiple clinic visits, and institutional obstacles, such as access to clinical trials and access to providers. So with that, thank you, and I'm going to turn it over to Dr. Chong.
Thank you so much, Dr. Huang, for your insights. Greatly appreciated. Dr. Huang will now take off her sharing, turn off her camera and microphone. And we would like to move forward to a very important topic, which is the treatment of cervical cancer. Dr. Chan, if you could turn on your microphone, start sharing your slides and your video.
Okay, thank you so much. Can you see me? Can you hear me?
Yes, we can. Thank you.
Thank you so much for this opportunity to discuss the treatment options for the cervical cancer as well as the clinical trials. But I feel a little bit kind of isolated after hearing very excellent presentations on the cervical cancer screening, HPV vaccination. Even though we have a wonderful method to eradicate cervical cancer, we still dealing with a very significant health issue, especially in young women. So I feel a little bit sad before I started this presentation. So today, I'm going to touch on some of the current treatment strategy for cervical cancer and give recent updates on clinical trial cervical cancer landscape. As we heard previously that cervical cancer continued to be worldwide health problem, for example, being the 4th most frequent cancer in women, but also still problem in the United States where we have a very systematic cancer screening as well as a vaccination. Still over 4,000 women, it shows 4,200 women died from this preventable disease annually. On top of that, median age of cervical cancer is only 49. So therefore, not only affect the patients, but also affect the patients with their young family, which can be extremely difficult to many people in that situation. So this slide shows treatment options for cervical cancer before I dive into more of recent up-to-date. So cervical dysplasia, precancerous lesion that can be treated with excisional biopsy, either conjugation or lip procedure. When the patients have early disease, that surgery can be offered, and the patients may need adjuvant treatment depending on their risk factor found in the surgical specimen. Patients with a locally advanced disease, which is a stage 1B3 to stage 4A, the definitive chemoradiation is a treatment of a recommendation. For the metastatic disease, unfortunate situations such as stage 4B, a combination chemotherapy with a multiple agent has been a treatment option. The treatment of advanced recurrent metastatic cervical cancer has come along for last couple of decades, and the data on novel combination and therapy provide hope for further progress. Before we transition to more details on immunotherapy in the cervical cancer, it is important to understand the rationale for the immunotherapy in the cervical cancer. Development of cervical cancer is directly linked to HPV infection, as you've been here. Then, immune system defect play a significant role in cancer progression. So HPV E6, E7 induce the cascade of the cytokine and the T cell signaling. It also induce increased interleukin-2, also enhance myeloid-derived suppressor cell, MBST infiltration, as well as a crack T cell. Also, it can upregulate PD-L1, which is a very important immune checkpoint. As you can hear, that virus associated or induced cervical cancer that is kind of intuitive to consider immunotherapy as their treatment option. So now I'm going to discuss how immunotherapy has been used in the cervical cancer. Before we move on to the current situation, I like to bring the attention to previous study, which was a GOG 204 that established combination of taxane and the platinum treatment as a standard chemotherapy for metastatic recurrent cervical cancer. Then 2009 GOG 240 demonstrate that addition of bevacizumab to combination chemotherapy showed the benefit with extension of median overall survival from 13 months to 17 to 18 months. They're based on treatment combination with the bevacizumab, taxane, and the platinum-based chemotherapy on top of that immune-related environment that we just discussed in the cervical cancer. That led to a lot of interest in immunotherapy in the cervical cancer. There has been a couple of studies prior to this Keynote 826 led to this very large international randomized double-blind phase 3 trial. This study was patients with a persistent recurrent metastatic cervical cancer without prior systemic chemotherapy with good performance status, was randomized to pembrolizumab, which is immunotherapy, 200 milligram intravenously every 3 weeks, with the chemotherapy with or without bevacizumab. And then other patients receive a placebo instead of pembrolizumab. The treatment continued until death or radiographic progression of a disease or unacceptable toxicity or study completion. For this study, patients was given up to 35 cycles of pembrolizumab or placebo. And the chemotherapy was kept to less than 6 cycles of the combination of chemotherapy. The primary endpoint of this study was overall survival as well as progression-free survival. This data demonstrate that in your left, the progression-free survival, the patients with the PD-L1 combined a positive score or CPS of 1 or greater was 10.4 months in the patients receive pembrolizumab compared to 8.2 months in the patients who receive placebo with hazard ratio of 0.62. That also led to improved overall survival with 24 months in pembrolizumab arm versus 17 months in the placebo arm. This result of a phase 3 randomized trial showed clear improvement among the patients with the PD-L1 CPS score of 1 or greater. When you're looking at the safety overview, and especially attention to the center, treatment-related AU grade 3 or grade 3 and 4 adverse event occurs 68% in pembrolizumab arm versus 64 point in a placebo arm. And the serious AE occurred 30% versus 23%. Then adverse event led to discontinuation of any trial agent was 31% versus 32%. Respectively, and of all trial agents was discontinued 3% versus about 2% patients. This slide demonstrates the recent update on the subgroup analysis. Progression-free survival and overall survival benefit has been shown in the histology of the squamous cell carcinoma versus non-squamous cell carcinoma, and the platinum use, either carboplatin versus cisplatin. And patients who receive both pembrolizumab and bevacizumab, as shown here, have shown an additive effect on outcome that should be considered when deciding which agent to use. How about beyond immunotherapy? There has been some study has been done recently and it led to FDA approval. That tisotumab is investigational antibody drug conjugate directed to tissue factor and linked to microtubule disrupting agent MMAE via linker. And tissue factor is a protein highly expressed in cervical cancer and other solid tumor. In the right side shows how antibody drug conjugate works in mechanism of mode. How about the study? Innovative 204 was a single arm phase 2 study evaluating this tisotumab vedotin in patients previously treated recurrent and/or metastatic cervical cancer. The patients progressed their disease during or after doublet chemotherapy with bevacizumab. The study was kept the patients less than 2 prior systemic chemotherapy with a good performance status. Over 100 patients enrolled in this trial. Patients was given tisotumab vedotin 2.0 milligram per kilogram intravenously every 3 weeks until progression of a disease or unacceptable toxicity. Our primary objective was objective response rate. Secondary endpoint was objective response rate by investigator, duration of response. As you can see here, that tisotumab shows confirmed over about 24% confirmed objective response rate with a 7% of complete response. As you can see in this waterfall plot, clinically meaningful durable response has been observed about 80% of entire patients' population with the regression of the disease. Median duration of response was 8.3 months. That led to FDA accelerated approval pathway with this exciting agent, and then now being studied with the phase 3 study with the investigator choice of chemotherapy in the randomized phase 3 study with this agent in patients with metastatic cervical cancer as a second or third line recurrent cervical cancer, but also has been investigated in the combination with the other agent, including pembrolizumab. In this study, there has been a pre-specified adverse event of interest, including ocular, bleeding, and neuropathy, as shown in here. Ocular adverse events were mostly mild to moderate and the resolve and manageable with eye care plan. Most bleeding event was grade 1 nose bleeding, and the majority was resolved. Most peripheral neuropathy, which is due to active agent MMA-related toxicity, were grade 1 and manageable with the dose modification during follow-up. As you can hear, there are ocular adverse event happen with this agent being antibody drug conjugate with the tissue factor to the tissue factor. So therefore, mitigation of ocular adverse event are very, very important as education and a plan when we're taking care of our patients. So patients mitigation such plan will be confirm the patients receive cortisol or vasoconstrictor eye drop prior to infusion, and also during the infusion apply cold pack covering the eyes during and the 20 minutes after infusion is strongly recommended. And the patients will also use their corticosteroid drops 2 times throughout the remainder of the infusion day. Then also mitigation assessment, ocular adverse event is very important. The patients also, after infusion, the patients need to use eye drop 3 times a day for 2 to 3 days after infusion. So many good patients education and then good establishment with the local eye doctor is very pivotal to avoid and elevate their symptom. Go beyond the current treatment option that led to FDA approval. I like to move forward to give you more up to date on the recent presentation. As you hear me previously, locally advanced cervical cancer will be treated with a definitive chemoradiation. But the benefit of a potential immunotherapy, this study, COLA study, was designed as a randomized, double-blind, placebo-controlled phase 3 trial. Patients with historically confirmed cervical cancer, adenocarcinoma, squamous cell carcinoma, or adenosquamous carcinoma histology, and if they are high risk by FIGO 2009, which means the stage 1B, 2B with the node positive, or stage 3A to 4A with any node condition can be eligible for this trial. Patients was given Durvalumab, 1,500 milligram every 4 weeks, up to 24 dose in conjunction with the definitive chemoradiation. Primary endpoint was progression survival. A secondary endpoint was overall survival. Unfortunately, despite that, some of high level of interest, this phase 3 CALA trial, Durvalumab in combination with and the following chemoradiation did not significantly improve progression-free survival in the patients with a high risk locally advanced cervical cancer in comparison to chemoradiation alone. Study safety was comparable in the both arms, and there was no new unaccepted toxicity has been reported. So this slide shows some selective randomized phase 3 immunotherapy trial in the recurrent metastatic cervical cancer. We heard about Keynote 826 using pembrolizumab in the combination with taxane platinum plus minus bevacizumab treatment. A similar study is also either completed or recruiting this time with a different type of immunotherapy with atezolizumab or progolizumab. And also that we hear a brief presentation of a CALA trial, adding Durvalumab to definitive chemoradiation treatment. Updated presentation couple of months ago was not promising, but there are another clinical trial, Keynote 818, a similar patients population using pembrolizumab, not Durvalumab, is undergoing clinical trial. We'll see whether they have a similar disappointing result or different result. And lastly, this slide shows other clinical trial in the recurrent metastatic cervical cancer. The first line, semipulimab, the result was very robust with the objective response rate 50% versus 19%. But unfortunately, due to sponsors or companies' decision, they decided not to proceed with the cervical cancer as FDA labeling. The next two shows another combination with the PD-L1 as well as a CTLA-4 inhibitor in the cervical cancer second-line treatment. We have some preliminary data, but unfortunately, this study has been closed in U.S. They expanded the patients' enrollment internationally. The next, you can see that the TIL trial has using the patient's own T lymphocyte, and then giving the patients after overgrowing the TIL, holding promise in the different patients cohort. The study was done in the more than second line of a treatment. Then they moved to chemo-naive patients population. Then now they opened the cohort to prior immunotherapy trial. This is a very exciting treatment option. Hopefully, it will be additional treatment option for this patient's population. And lastly, you can see a couple of biospecific antibody treatment to increase immune reaction, not only PD-L1, but the CTLA-4 or TGF-beta as well. So this will conclude my presentation. Thank you so much.
Thank you so much, Dr. Chan. That was an amazing lecture and very educational. I'd like to ask all of my panelists at this time to turn on their cameras, and we will take questions from the audience. And I also have some questions for my panelists. I will start with Dr. Kuhn. Dr. Kuhn, thank you so much for your screening. I noticed you mentioned, and I found that very interesting, treating patients with dysplasia and then subsequently offering HPV vaccine to that patient population. Can you talk a little bit more about that? Because it's not something that many of our providers necessarily think about or maybe even offer.
Yeah, sure. That's a great question. So in that study that I mentioned, it was the biggest, double-blind, multinational study that we have to really study these women who are older that may have an HPV infection and indeed need to go on to get treated. The thought is that, whether you're doing a colposcopy and biopsy and you go back and you don't see anything on the cervix versus an excisional procedure, that the HPV has been eradicated. And so then you're dealing with a cervix that no longer has an HPV infection. And so these vaccines then come into play because you no longer have the HPV strains that the vaccine is targeting. So really, it's like a cervix that is that of a young child. I mean, not comparatively because there's differences in ages and ability to clear infections, but once you've done these excisional procedures, then they found that the vaccine is more amenable in protecting against HPV.
Wonderful. Thank you so much. And I also have a question for Dr. Wong. Dr. Wong, tell me, so really interesting data on the insured and the urban, non-urban patient populations, as well as the poverty-ridden areas. What do you think, and this is a hypothetical exploratory question really, what do you think we could do here in Florida, maybe in collaboration with the Department of Health, perhaps through a grant, where we can make a better impact to really address these issues in those high-risk areas?
Yes, so I love that question. I think, the data is pretty striking because, when you look at race and ethnicity and the high areas of cervical cancer incidence and the low rates of HPV vaccination, it doesn't all kind of fit into our idea of which areas are rural and which areas are high in poverty. And it doesn't all kind of line up in that same way. So I think some of that data that you presented with that geospatial mapping is going to be key to helping us get that message out there to better educate not only patients, but providers. I think the change in the guidelines probably caused some confusion among providers in terms of when do we stop? Do we do both HPV and Pap smear? And so I think some of that shift with the guidelines has probably caused some decrease in screening as well as the pandemic. I think everybody saw the across the board cancer screening decreased. But I think, utilizing the app that Dr. Kuhn presented to help our colleagues who are not as familiar with kind of the algorithm and to get into those areas and just really educate not only providers, but patients to be asking for Pap smear and HPV screening.
Thank you so much. I have this vision of us going around in this mobile bus and the most desperate areas in our state and giving them that self-pap thing and go to the bathroom, come back, we'll collect it. Here's your first shot. And come back for your results and your next shot. What do you think?
I love it.
I would volunteer.
Yes, I would volunteer too. I love it. Like just getting out there and offering it to them, because even though it's supposedly offered through the vaccination program, the data is we are not vaccinating our teens, right? It's not happening in Florida. So we need to come up with ways to do it. And if we just drive around, I would love to do that.
Excellent. Thank you so much. Dr. Chan, you touched on TIVDEC, which I was so excited about having an opportunity for second line treatment, because second line that patient population had nothing. And, these are young women coming to us with horrible disease, intractable pain, sometimes penetrating the parametria, invading the nerve roots. They're in excruciating pain. They've already done radiation therapy. They've already done, Keytruda, Bev, and now what? And I was just so happy that we had this option for our patients. Lots of times I talk about response rate, true response, partial response, stable disease. And then when you add all of that up, what is the total disease control rate for that drug?
Yeah, I'm also very excited about this treatment option. But first, that the patients, as I presented earlier, that when you're looking at the waterfall plot, I mentioned about the primary objective of the study was the objective response rate, only include a complete response as a partial response, which was 24%, which is fantastic given any clinical trial, not only for cervical cancer, but also all the GYN cancer. But then if you add the stable disease, another 50%, then overall, disease control rate become around 75-80%, which is fantastic. And also the more also exciting news is the duration of response, 8.3 months. And then the patients, the range was 4-point-something months and not reached yet. So when the patients respond to treatment, there is a high likely respond for a long time, which is very, very benefit the patients to stay on this treatment for a long time.
Thank you so much. I think we've passed our time for our program, but it was such a wonderful program with these amazing experts. I really enjoyed each one of your presentations, and I thank you so much for participating in this program with us. At this time, I'd also like to once again thank our sponsor for this webinar, as well as FLASCO, both SeaGen and FLASCO. Thank you so much for allowing us to partake in this webinar today. And to our participants, I'd like to thank you for joining us tonight. And I hope you will join us again for future-based FLASCO programs.